Welcome back. How are you, Renee?
Hey, I'm doing great. How are you?
Fantastic. Spring is just around the corner, so I'm getting ready to plant and getting everything in order. So it's about to get real farming.
Have you looked at the Farmer's Almanac? Are we supposed to get some of those late hitting snowstorms this year? Because,
I
I still remember Easter weekends, other weekends into April, even the 1st of May getting snowed upon. And this year we got dumped on kind of early and then nothing happened. So are we waiting for more snow or what do you think?
I'm not even gonna think about it. I mean, I can think back to February. It was 50 degrees, and I could have been planting. So I don't know what the weather's ahead of me in the next 30 days. We're just gonna hope for the best.
You're not going to just worry about that and be all upset about it. Because,
I'll try
you
not to.
know, 'tis the season. About this time of year, those farmers at the State House get an itch to go plant, and we means that we might be getting done soon. So, woo woo for warm weather. Hopefully, it moves us on.
We can only hope.
Yeah. So today we're going to talk a deeper dive on where to stay in a crisis if it's not going to be inpatient hospitalization. And we started the last time we talked about the big continuum of care of what a crisis continuum should look like, and starting everything all the way down to like how do you access it and what are those levels. But today we're going to dive into 3 levels that are kind of deeper in a deeper conversation about what do they look like and how do they work. And then we're going to then talk some about the another level of care that we're going to go diving into deeper next time. So this week we're going to talk about subacute and crisis residential and access centers, all those things. You're like, what in the world? If I was in crisis, where would I stay? So Jason, what are you excited about talking about today in that residential space?
Well, when you're talking, I just started thinking, really what we're talking about is those diversions, right? When we want to be diverted from the hospital,
Yep.
and when we don't want someone to be at that most acute level of care, and maybe they don't need acute level of care, but they need some place to go that has high structure and support,
Right.
and the clinical needs for them. And so really that's what these levels of care are. So as we think about crisis residential, sometimes it's called crisis stabilization, thinking about what is that? Where are those places? And what role do they really serve? Because I think it's really confusing sometimes, Renee. How often do you talk to someone and they're just not sure what the other levels of care are?
Right. And to be fair, in our state, for one, we talk about stabilization, but you can do it in a facility, but you can also do it in the community. And I know most people I've worked with, if they can do at home in a community of choice, that's where they prefer to heal and to get better and to get supports if they can. And then there's sometimes when that's not a choice and you need to actually have some time out of the house for various reasons, or maybe are less homed and don't have a place that's stable to live, or something has happened in the place that you were residing and you needed another place. And so it really just depends on each individual. So it's nice to have the full level or array of services at our fingertips, because it is nice to be able to be flexible in that based on people's needs. At least that's the point, and that's what the policy is about. So it is nice to have that, but it is pretty confusing. Some people don't really understand where they go. And so I know that, there is a difference between stabilizing in the community and stabilizing in residential. And one big obvious difference is where you're located, right? You're either in a place or you're at home. And I don't know if we've talked about this, but why might somebody want to be stabilized at home if they can? What are the benefits of that? Off the top of your head, what are you thinking are, why would people want to be stabilized in the community if they could?
Well, I mean, generally it's a lot more comfortable if you have a home, right? And so this is really comes down to those who have a home. And it kind of goes back to medical. I think as we learn more from healthcare and as we see the merging of behavioral healthcare with the larger healthcare system, then we start to think about things in terms of, is this facility based or is this home based care? And so I'll use an example of a hip replacement. There's sometimes that you have your hip replaced and you need to go to a short-term facility because you need the additional nursing and support to get back and rehab that hip before you can go home. However, in other cases, you're able to go directly home after the procedure and have in-home nursing and other supports brought into you. And so really it's the same thing. Unfortunately, over the years, we've kind of gotten to this mentality that if you have a behavioral health condition, you have to go to a facility. And I
Right.
think that that's done harm because we've not been able to think about home-based care in the
Mhm.
same way that we've always thought about home-based care when it comes to medical conditions.
That's a really good point. The hip story. Oh man, you brought up a story, so I'm gonna have to tell it. So I have a family member, man, that had hip replaced. It was kind of during the time of COVID, And I believe another family member talked them into, well, I think they could just take care of this at home, to your point. And then it became pretty evident pretty quickly that they couldn't. And then they had to go right back to the hospital because bad things happened and they didn't. And so that's one of those that I would have loved to have been the fly on the wall with the doc, because I could have told them it wasn't going to go super well. And they didn't probably tell the whole truth about what was happening at home. And probably would have been better off to be stabilized in, to your point, like a rehab facility for a few days to really get that kind of stabilized and kind of under control, pain managed, things like that beforehand. And so it's not a judgment situation. There's just sometimes you need a few days to maybe get that med changed, which can happen in crisis stabilization. You may need to have the doctors to be able to get to you and have access faster. So maybe you need a place to be. So it's not a stigmatized situation if you need crisis stabilization in a place, because there's a place for that. And some people, it is, if you're on medications, maybe you do need to be someplace where people can see you more readily, or maybe there's a substance issue and you're in an active detox, or in a situation where you need to be away from the substances you were taking, or whatever those situations are, and you need to kind of get stable before you go back into the community. And stabilization in a place is super helpful for that. And so it's not this is better than that. It is, to your point, just like healthcare. If it's, if you could do it in a community, great. And if you need a place, great. And you should be able to access both. And so today we're talking about those particular things, but there's another level of care that rolls in this that really gets messed up in definitions, and that's subacute. And I'm sure people have heard about subacute. And Jason, what have you found that subacute is supposed to be versus what we've heard it is?
Yeah, I've been doing this for a long time, Renee, and I work on projects where we're talking about subacute, and everyone uses subacute in a different way when we're having conversations. And so I actually found myself here the last couple of months working on a project, and I have to keep going back and reading the definition because I hear the word subacute thrown out in so many different references that I get confused because it's referenced in so many different ways. And so I finally had to ground myself. And when I hear it, I just have to repeat to myself, subacute is post-acute. So if we go back to the medical definitions, subacute means it's after you've been treated in an acute care situation, right?
Yep.
So it means after acute care. And so if I keep saying that over and over to myself, and that can occur not just in a facility, but also as follow-up care at home. So subacute can occur anywhere, right? But it generally occurs after an acute condition. And to me, that helped me understand it, right? Because so oftentimes, I've been in rooms where providers get mad well, they won't take anyone in the subacute unit. How do we get someone in the subacute unit? They only take people from their own unit and then they transition them to subacute. Well, silly, that's what they're supposed to do because subacute is a transition from the acute care unit to prepare someone for transition back home or to the next place. And so oftentimes, even as professionals, they're completely misunderstanding what the continuum of care should be. And then it muddies the waters even further and it hinders people from getting the right care at the right time.
Right. And it gets my brain thinking about that. I don't know that you can actually place people directly to subacute. I don't think that's really the intent of that level of care. It is, to your point, supposed to be transitional step down, not placed directly to, because who decides that you weren't acute enough to be acute? Somebody in the acute unit is who decides that. So if you're talking that level of care in the first place, you've already had to have a screening at acute level to get there. So I guess you could get to that level, but you've got to go through an emergency department or somebody who is trained to think through what is acute to be able to say they could go from ED to subacute and bypass acute. It's not just any provider can stick people in it. And that, you're right, that's a big misunderstanding. And to muddy those waters, you're really going to like this next one, because we told everybody we would talk about access centers in a more deep dive. And I thought I'd read the definition, because this is where subacute got super muddy when we started talking about access centers. It says that access centers are located in a crisis residential and subacute residential settings with 16 beds or fewer that provide immediate short-term assessments for persons with serious mental illness or subacute use disorders who do not need inpatient psychiatric hospital treatment, but who need significant amounts of supports and services not available in the person's homes or communities. So this is a different level, and it kind of is a combo, if you will, of different types of crisis services that kind of come in this one place. And so I'm guessing the idea not only was for access centers to be on the front end to do evaluations into the system, but maybe step down on the way out of acute because they say that they have subacute beds.
I think it would be best if we just said that was a mistake, and go back and do it over again. This is where we need a do-over because I think the way access centers, at least in Iowa, was defined wasn't really what anybody meant. And so I think this only furthers that confusion about where
Yeah.
do I go, when do I go, and how do I do it? Kind of like we talked about access centers in the last episode, that, if we cleaned up the definition and we had universal understanding, then we'd be able to utilize them to their fullest efficiency. And I think as we move on, to further episodes, we may find that that concept of access centers, it may have run its course, right? As we move to CCBHCs, and other points of entry into the system, it could be that access centers is no longer a thing that we kind of separate out, and so I think because of this conversation, that would be best, because we've really lost our way when we have the conversation about access centers.
Well, to give our listeners a history lesson on how in the heck we got to access centers in the first place, this really came from a push from sheriffs and deputies who didn't like to have to sit and wait in emergency departments for people to get admitted or for people to get treatment, so that if they brought them to the emergency department for stabilization or for whatever. So they really were looking for another place where they thought they could just drop people off and they would be able to stay, get an evaluation, and then basically a warm handoff. Somebody else would take care of it. Except that even in the initial development of an access center, it was never a locked facility. You've got officers who just assumed they were going to drop people off and they were going to stay. Guess what people don't do when officers walk away? They don't stay because, well, they didn't really want to be there, and you can't lock a door and make them stay. And so from the get-go, to your point, Jason, it didn't go either from intent for design or other things. And then that requirement that subacute was attached to it always felt really weird, because access centers, the whole idea of it was on the front end as a place for an evaluation, a place for a diversion from the ED. And you just told us the definition of subacute, which is post-acute. So there was nothing acute in an access center at all. So how did post-acute land in the access center? It's definitely a mystery. And so I think we've confused people further. So even though that is the actual definition, we aren't making it up. It just didn't really clarify it, to your point, what we were trying to do.
Yeah, and it makes sense to me, right? When we think about crisis residential or crisis stabilization unit, oftentimes when someone's seeking out services, that would be a great place. They're staffed 24 hours a day in rural areas. They're small units, 5 or 6 bed units. They would have the staff on hand. That's a great place you could go for an immediate evaluation. If you needed some place to stay, likely they might have a bed. That would make sense on the front end, right? And so some of those places could double as an access center. But really, this is really just moving us closer to a truly collaborative care model. We talked about that integration, and we've been talking about that for several podcasts now. As we move to a more integrated system, then it gets us away from this having to have a special place to go to get access to things, because the access point should be anywhere that you go.
That's right.
Any provider that you go. And so as the system moves us and we push toward value-based care and integration between physical health and mental health and substance use disorders, then we're not going to need to separate it out. And I think in some ways the access center, saying it as a separate place, really did it injustice, when we should have been focusing on how do we collaborate better and create that no wrong door approach.
Yeah. And I think too, just to your point, we're talking about the whole concept that drove the decision to create these in the first place. It was never built to do what the constituent group who wanted it was to do. I think back to another podcast or two ago, we talked about kind of urgent care behavioral health clinic might have been closer had we really gone down that route, because subacute actually changes a couple of things. Subacute beds are under a different licensing standard. They're under inspections and appeals. They are more licensed like an actual hospital bed. It's not like your regular crisis beds. It's not like anything else in the regular mental health system level of care, or even substance use beds. It's different. And it has to require a higher level of doctors and nurse staffing So it makes it really complicated to create that level of care outside a hospital. So when they were saying, well, we want to do subacute at this other place, but there's no doctors on staff, there's no 24-hour nursing on staff, and it doesn't work because of the licensing standards of post-acute require those things. So it makes the most sense and the easiest within a hospital setting because they already have the staff available. Now, where I get really interested is this idea of a community-based subacute. I'm super stoked to learn more about that moving forward because I'm a tad confused about, well, how does that work? Because if there's, like we just said, all of these different requirements for who has to be available and on staff and around for it to be that kind of bed, how does that happen in a community? And so I'm super excited to learn because, if they can do more things at home, we know people would like to have more care at home, just like in your medical care when it's appropriate, would love that. I'm on board, but I don't know if, some rules and laws have to change to make that happen. I'm not sure because it's definitely, they don't all line up now, as you know. So I know that you've dove into this and you've got some more deep dive on subacute. So tell us what you've learned.
I don't even know now. Well,
Hey.
we've learned a lot, and I think, you summarized a lot of that. And I think as we differentiate subacute from residential, then we start to get a better understanding of when the appropriate placement is and the appropriate timing of all of those things. And so as we define and figure out licensure, I think licensure and accreditation is a huge barrier. And as we start to align that, but part of it is as understanding the continuum of care, right? If we really want to transition patients up and down based upon their level of need, then we have to understand what that care continuum looks like. A couple months ago, Renee, I did focus groups in another state because they have issues around beds, and I'm counting beds again. I'm in a system, and they're saying we need more beds, and I'm like, do you though? And I go, help me understand your continuum of care. And there was silence.
Yeah.
And I said, well, tell me what the levels of care are. And so they said, well, there's this DHS manual that says stuff. And so I go to the DHS manual, and of course, what they call it is a different name in the DHS manual. So I have to do a whole crosswalk of the names of the different things to understand it, right?
Mhm.
And then when I do that, I map it out on a piece of paper. And I'm like, okay, this is where I had to go into a deep dive of what is subacute for you, right? How are you using subacute? And as we started to flesh that out, we realized that there were entire levels of care missing.
Ooh.
And so it became very clear as to why there wasn't enough acute care beds, because no one could ever leave the acute care bed, because there was not subacute, there was not long-term residential, there was not any place for someone with a serious persistent mental illness to go who needed long-term supports. There was only crisis services. So
Right.
every time there was a crisis, there was some place for someone to go, but there was no place for someone to go for stabilization over
Wow.
the long term. And I think that's part of when we think too much about crisis and too much on the front end, then we forget what we need to transition people from the system and support them after the fact. And so that's where I get excited about subacute in the community. I get excited about crisis residential services in home, right? Like, how do we help someone support them in their home when they're experiencing a mental health crisis, as opposed to having to pick up and go 60 miles away to a crisis residential unit, which
Right.
is important, and it's important to have access to that, but it's not needed every time. And so that's really where I think the opportunity is here.
Right. And when you're talking about access centers, I think to your point, the important conversation is what services were supposed to be available in that kind of system, right? And whether it's at a location or multi-location with multi-doors, it's what you were trying to accomplish with that continuum of care that matters. And so with access centers, the goal was to have a place to go for that kind of quicker evaluation to determine the need of the person, right? Were they safe to be not in the inpatient unit, or did they need to go to the emergency department? And what did they need? It had beds or access to beds for short-term stay if necessary, or access to wraparound services in the community if necessary. And then those warm handoffs for the ongoing resources. So it kind of gave you that case manager, navigator, if you will, whatever title they call them, person that can kind of be responsible for that person to get them connected to the next service that they needed to help them stabilize. And as we worked on this project, we realized, what was that number? It was like less than 2 months. Was it like 60 days, or I can't remember if it was 60 or 90 days, that if you didn't get services established that were of use. And if not, then the crisis cycle started again. And that's the piece that you're talking about that's missing. Is it's not, maybe we might get that immediate response down. Say we get the calls down and we get the mobile response down and we get all that stuff done. Great. But if you don't get them connected to the rest of the system within that 60 to 90 days, it just starts the crisis loop again. And sometimes some people are even faster than that. So it's not helpful. This is where my soapbox comes in, to hand somebody in crisis an outpatient therapy card and say, here, get an outpatient appointment, which might be 3 months, 6 months, 9 months from now. Outpatient, I was always an outpatient therapist, should never be the crisis plan. That is silliness 100% of the time, because what are they going to do in a crisis? Their number, if you call an outpatient therapist, says if you're in crisis, dial 911. It might say 988 today, but automatically that's what the call says. And so that means they're not part of the crisis system. So for that to be what we do for follow-up for folks is just disheartening and completely wrong, because people need, when you're in a crisis medically, I don't need a, hey, here's your appointment for your doc 3 months from now. I need an urgent care, a fast care, whatever those things are called, to get in if I'm really sick, to get some help. And so we've got to talk about, like you're saying, that next piece of that puzzle. Access centers, what they were supposed to do and where they're located is irrelevant to what we're talking about. It's more, what was that continuum to do? So I know, Jason, you're thinking about that in a region that you're working in. How is that being processed when you're thinking about what are the services supposed to be, not where are they on a map?
Yeah, so really what we're looking at is how do we bring all the individuals in a community together to create a no wrong door approach, right? And so we think about collaboration and integration across systems is what's really important. And, I'll just throw that's out there, right? There's 85 critical access hospitals who have emergency departments across the state of Iowa. Why are they not part of this? They're open 24 hours a day. One of the things we're looking at is how do we connect the behavioral health providers, those crisis residential facilities, all of those parts of the system with those local emergency departments, with the acute care inpatient programs, and how do we then have collaboration across them all so patients aren't getting moved to the wrong level of care at the wrong time, but that we're working together using warm handoffs and integrated systems that move people together to the right place.
Yeah. And that's brilliant, because we also in our rural communities struggle with workforce, right? And so instead of having yourself a new building that's an access center with subacute, I'll put it in air quotes, or whatever, where it had to have the certain nursing levels and the certain doctor staff ratios and whatever, and you have your neighboring community access hospital who has that, why build a new building to make something that could be done in partnership with something existing that has to have that already to function? They can't be a hospital without those things. So that's brilliant, because it really helps us duplicate and kind of multiply our workforce more so, because some critical access hospitals, we've been to a few, beautiful and empty, not a lot going on. And so they've got staff or staff on call or whatever to keep it open, but there's not a lot always going on there. And so to be able to partner a system like a crisis system who needs that level of support, but then cross-train people so that they actually know how to help, and not just heart attack, stroke, those kind of things, but actually help in crisis. That could be a huge win. And so some of these conversations, although they're painful and they seem slow and that they're not really moving to the speed we want them to, are really exciting if you look at big picture, because we're really starting to meld together behavioral health, mental health, and healthcare, which should have never been separated in the first place, and put back into places, especially rural, where you can have that one-stop shop and get some help with it you need. I know that
wait a second. I started to chuckle because I remember the time we're walking through this beautiful new hospital, and they're trying to find the light switch in the ED because the lights were all off, and they wanted to show us we're doing a tour of the hospital, and here we are. There. There's nobody there, like nobody. It's a ghost town, and
I got to see so much equipment that I've never seen up close, because I'm not really into hospitals. And so there was brand new equipment everywhere in that ED for all the things. I don't know what they were, all the things. And we got to see all of it because they were so proud to show us. And they're not one person.
Nobody.
We could tour the whole dang hospital that day. And yet, they're fighting with us maybe about being involved with behavioral health or dealing with elders or dealing with opioid crisis. all the things, which is ridiculous to me because it's like you have a beautiful hospital sitting here empty. But on this topic, you also kind of roll into some data on some things. So did you have some ideas of some stuff you wanted to chat about what you've seen related to either access or subacute or residential that you wanted to share with everybody today?
Well, I was going to, guide people. We're going to put a couple of articles, in the show notes. And I think it's really important as we have this conversation. A few months ago, there was kind of a good article about how, the behavioral health industry has really moved beyond healthcare integration and really looking at how does physical health now come into the behavioral healthcare system, right? How do we really start looking at treating the whole person? So it's not just about healthcare integration across the board. It's about physical healthcare, taking a more honest look and approach toward behavioral healthcare, but also behavioral healthcare getting on board with looking at the whole person and managing diabetes and managing all of those co-occurring issues that occur with medications and other things that are directly related to someone's behavioral health. And so I think that it's important that we think about how are we doing that in a way that truly makes sense.
Yeah. And so when we're talking, before the show started, you were talking to me about a level of care I've never heard of before. And I thought right now would be a great time for you to share this with me one more time and help my brain and our listeners figure out how this residential piece might fit into this picture. I don't know that it's something necessarily we want in our state, but I thought it was a very interesting conversation. So in working with a different state, you heard about a new level of care that we don't have. So talk to us about that. What did you find?
Well, I did. I mean, so I'm looking at gaps in continuums of care, and so I was learning about psychiatric residential programs, and lengths of stay in those, and how important that is in the continuum. And then I learned about secure residential facilities for adults who have mental illness. And I was fascinated by this. I'm like, okay, there's a 16-bed unit. And they're like, yeah, we just built another 16-bed unit, and another company's doing that. And so now I'm like, there's 32 beds. And I'm like, yeah. And they lock people up. And so that's where we send everyone. I'm like, tell me more.
Tell us more. So, okay. So we have 16 beds. That means for those wondering why 16 beds out there, that means Medicaid can fund the beds because there's what's called the IMD, or an institution of mental disease exclusion, that over 16 beds Medicaid cannot fund. And it's a battle at Congress. They're talking about maybe changing it. There's rumors that Congress is talking about even adding some Medicaid options in incarcerated individuals, because all of that stuff stops when you go incarceration. And so you can't get Medicaid, Medicare, Social Security, none of it. So they're talking about those things. But for right now, as of the time of this recording, IMDs mean over 16 beds. So they've already cut it down to 16 on purpose to get Medicaid funding, but they locked the door. How does that work, Jason? How does that even, have you visited one of these? Are you going to get to visit one of these?
I have not. I'm going to make the time.
You have to. You absolutely have to. I need to see pictures. What is this?
I'm excited. I love it when I learn new things, right? And so, and we know, right? Sometimes people make up levels of care. And so I'm anxious to learn more as we go through the process, and that's the challenging part is when we look at the opportunities we have as we go through different levels of care, then sometimes there's a gap and our legislators or our departments of health and human services panic. And then they create something and don't understand the consequences that come along with it. And then over time, there's drift, right? And then those 16 beds turn into 32, and then those 32 beds turn into even more. And then we realize that we've started something and we really don't know why, because there's actually another problem, right? And so why did we get to this place? And so we're asking those questions right now of
I am super curious as to what in the world level of care would require you to lock somebody in a building. Because the ability to lock people in my world, consists of inpatient hospitalization. But I think if you're on a locked psychiatric unit, those are locked. There are some nursing skilled facilities, memory care units that are locked to protect people. But even in those cases, Most nursing homes have a door that if you push the door, the alarm goes off, but you can open it and you can keep going. Because my grandpa used to run away,
Mhm.
according to the family stories, and he was fast. And so he'd hit the door at a certain speed and then just keep going, and then I'd have to go chase him. So he wasn't even locked in, right? So back to locked, I mean, you kind of have to be incarcerated in our state to be locked in something. So I'm wondering if these are like maybe civilly committed folks that could be locked in, because that could be a thing, maybe
We're
that
we're
they've been committed, and so therefore they're civilly committed or they've committed crime, then they can be locked in. But if they're just people who are experiencing mental health concerns, locking them into a secure unit, I don't get it. And this is
and
gonna
it
be
and it
one to
might
come
be
back.
and it might be a civil commitment issue. And so we're going to figure that
Maybe
out.
it is,
But
maybe it
still,
is.
it would be interesting to see a civil commitment issue that wasn't in more of an acute care setting. Because
Right,
generally you see that more acute
right.
and not at a lower level, which this would indicate based upon how it's labeled.
Well,
Now,
you can do outpatient.
well,
You
sure.
can do some outpatient like competency to stand trial. You can do that.
Right.
That is a thing that's
You can do court.
community
I mean, there's
based,
court ordered outpatient treatment.
because they might
Um,
have like a GPS
yeah,
monitor or
yeah,
whatever, or
yeah,
you can't leave home kind of thing. So there's options, but
yeah.
boy, that makes my brain really start pondering like, what is it? And so I know that's one of the exciting parts of our job is when people tell us new things, we're like, whoa, what is it? And so you got to go investigate, because it's like, that's an interesting level of care that I don't know, maybe there's a valid reason for it to be, and maybe it's something that we could learn that we could use. But to me, it's like, whoa, wonder what's in it, because it's like, I'd like to meet the people. I mean, are they certain ages? Are they only one sex or gender in one building? Are they mixed? Because that would be something. Because when I used to work with teenagers, you put two genders in a building, look out.
Mhm.
And so I'm like, well, what's going on in the building? So I don't know. I'm excited to hear more about that. But isn't it fun that as you work around the Midwest and as you work around the rural states, that people, I mean, everybody's looking for solutions. So their hearts are in the
Right.
right place. They're trying to do the right thing to get people services. But gosh, sometimes you're just like, wow, that's not something I had thought of. So it'll be fun to continue that conversation.
It absolutely will be. I can't wait.
So this week's Recovering Politician Self-Care Policy, I'm going to talk a little bit about coming back around to personal boundaries. And this one is just a reminder that for me to stay healthy, I've got to think about how I recharge my batteries and how I am. I'm an introvert by nature. I can be very extroverted in how I get along with others, but introverted in the sense of how I get my energy back. And as I now work out of the house every day of the week, and I people, a lot of people, just lots of people. By the end of the week, sometimes I'm just done peopling and I'm just out of that. And I need some time to think and need some time to sort of rejuvenate. So making sure I have space on my calendar, that thinking time, which was, it may sound ridiculous to active folks, that folks that are, maybe there are people out there that are like, I need to go be really active and run and exercise to get rejuvenated and whatever. And that some people are, but I'm a person that kind of has to have that think space. And so been working with a coach in my life that says, do you have that on your calendar? Do you have the time? Have you putting it on there each week so that you have some downtime so that you can really think? And then I can take a water class and not talk to people. And that's a good thinking time for me because I'm away from my phone for a big chunk of time on purpose. So I'm not dealing with emails and incoming stuff. And it's just me and my thoughts. And so for me, thinking about that. So I guess the messages for self-care is figuring out where you land on that energy continuum. Are you a person that needs alone time and quiet to kind of recharge? Are you a person that needs more activity and more people around to make you more energized? And so just to finish this out today, Jason, where are you on that continuum? Are you a quiet needing person? Are you more the energizing people person?
I fluctuate so much. And so, thinking about spring, I actually get recharged sitting in the tractor field cultivating, right? Because it's just hours and hours. I'm just sitting alone. And sometimes the radio will be on and sometimes the radio won't be on. I'll realize after 3 hours, the radio wasn't even on. I just had that time to sit and be. And so I fluctuate between that alone time to recharge and just think and be with myself to sometimes need to be social, right? And talk to people and get out and about. So I'm a mixture. It's not just one thing I need to go to. I need a healthy mix of all of it.
Yeah. And so just add to that, that's a good point. So it's really thinking about what it is that you need. So I'm just going to challenge people today to think about your own personal boundaries and what you need to set. And if there's things that you need to do to get that energy and recharge, because we are heading into spring, it's an exciting time of year and we want to be able to do all the great stuff. So today we did a little deep dive into some of the places that you might go for residential types of services, where to stay in a crisis, and whether that's in a community type of stabilization or it's in a residential stabilization or in an access center, or and we kind of talk through subacute and what is it or what people think it is. And as you can tell by our conversation today, it's kind of all over the place and it's not as crystal clear as people would like it to be. And sometimes people are just wanting to know, well, how do we stick people in subacute? Because it's kind of that whole mentality of we need more beds to stick people in. And so that's not the point. And so trying to make sure that we are all speaking the same language. And so this is not one that's super easy to understand, but as you can tell by our conversation, there really are really good things that these levels of care do. And they're options for people when they do get in crisis. They don't always have to be in a hospital. And so we want you just to know that those exist. We're going to have a lot of information in our show notes today about how you can learn to see what it's supposed to look like, how they're supposed to work, and give you some models out there of some great things that are on the horizon. Well, next week, we're going to dive into what is a CCBHC. I'm not even going to tell you the acronym. You're going to have to come back next time to hear it. See you later, guys.